TB. MJet has shown something. Not yet. MJ TB problem.
Morning, everybody. Presenting on behalf of Medicine 4, Frisky and Dusky. Presenting 31-year-old lady from West Bengal presented with the complaints of darkening of skin for 1 year, tremors for 2 months, and palpitations for the past 2 months. She developed generalized darkening of skin all over the body, insidious and gradual onset, and later on, past 2 months, she had developed tremors of both hands during activities associated with palpitations as well. There was no tremors at rest. There was also a history of weight loss, noted 10 kgs in the past 2 months with normal appetite. There was no history of vomiting, abdomen pain, giddiness, postural giddiness, no history of chest pain, dyspnea, no excessive sweating, no loose stool, heat intolerance, no polyuria, no excessive urination, excessive thirst, or excessive hunger. She was evaluated for the same in local hospital and diagnosed with hypothyroidism, started on medication carbimazole, and came here for further management. Past history, there was history of cholecystectomy, there was history of bronchial asthma in childhood, and she was on PRN metadose inhalers. Personal history, she takes mixed diet, no history of smoking or alcohol, her sleep, bladder, bowel habits are normal. She has been taking carbimazole for the past 1 month. And on examination, her vitals are stable. Pulse rate was regular with 80 beats per minute. Blood pressure 120/80 millimeters mercury. Respiratory rate of 18 breaths per minute. JVP was not elevated. General examination was unremarkable. No pallor, icterus, cyanosis, clubbing, lymphadenopathy. The major. And coming to the examination of skin, there was generalized hyperpigmentation with prominent palmar creases. The knuckles were hyperpigmented as well. Thyroid was not palpable, it was not tender. The eye examination was normal. Oral examination showed normal mucosa. Systemic examination, cardiovascular, respiratory, and per abdomen were unremarkable. CNS exam was also unremarkable. The reflexes were normal and gait was normal. There was no tremors at the time of examination. At the end of clinical history and examination, the impression was that there's a young lady with no comorbidities prior, as presented with generalized hyperpigmentation. There is a history of tremors with weight loss. The considerations and the anatomical localization we had thought in this patient was that thyroid gland, because there was significant tremors, palpitation, weight loss, showing a hyperthyroid state. And she had consumed drugs, and it may be modified as of now because we had not found any features suggestive of hyperthyroidism on clinical exam. She has also given a history, and on examination confirmed there is generalized hyperpigmentation. Palmar creases were very prominent, which is towards adrenal glands, and primary adrenal insufficiency was considered. And coming to the prominent knuckles hyperpigmentation, we had also considered B12 deficiency with pernicious anemia. Putting all the clinical impression together, anatomically we are localizing to a multiple endocrine involvement, multiple glands are involved. And the most probable etiology here, with a history, there was no history of a prolonged fever, there was no history of prior infections, there was no history of family of TBs. We had thought of autoimmune etiology. The initial and focused investigations are as follows. There was mild anemia, normocytic, normochromic, 84 was the MCV. The counts were normal. The LFT, creatinine, electrolytes were within normal limits. Mild bicarbonate was mild low. Coming to the thyroid studies, TSH was elevated with a low functional thyroid component, T4 component, that is 0.7. 0.89 to 1.7 is normal. And vitamin B12 is low normal, that is 320. And INTIBC also showed a lower transient saturation of 24%. ECG was normal, there was no arrhythmias. And we had done investigations in terms of adrenal insufficiency, where ACTH was much elevated. The normal is 40, 42, 46. ACTH is 406. ATM cortisol was low, 2.6, and post-synactin cortisol was also low, which is implying a primary adrenal insufficiency. HbA1c was done, it was normal. Further investigations in terms of multiple endocrine involvement with a confirmed clinical laboratory picture of hypothyroidism, the laboratory picture of primary adrenal insufficiency. The further investigations were done. Thyroid ultrasound. It was borderline to enlarged size with heterogeneously hypoechoic parenchyma, increased vascularity with no nodules, with no other calcifications, suspicious of a thyroiditis. Thyroid antibodies for thyroglobulin and TP1 negative. ANA for autoimmune worker was negative. Pernicious anemia, intrinsic factor was negative. Parietal cell was awaited. The CT abdomen in view of primary adrenal insufficiency had shown bilateral asymmetric, bulky, enlarged nodular adrenal gland with no significant fat density. Biopsy was not planned since the patient was wanted to evaluate further later. Finally, at this point, considering primary adrenal insufficiency, hyperthyroidism with the clinical history with rapid drug modified hypothyroidism with non-tender thyroid with no preceding fever illness with no nodularity and high vascularity, we consider autoimmune thyroiditis the most probable thyroid disorder here, and there is a low normal B12 as well. Putting these endocrine problems together, autoimmune polyendocrine syndrome 2 was considered, starting with the replacement of steroid prednisolone. We had also replaced levothyroxine. The further evaluation, which is adrenal biopsy, to characterize what is the etiology of adrenal insufficiency, is awaited because patient wanted to do it later. Brief information about autoimmune polyendocrine syndrome. Most common among the three autoimmune polyendocrine syndromes. The polygenic disease, it is because of lymphocytic infiltration of the organ-specific damage. Thyroid, there is chronic lymphocytic infiltration causing most probably Hashimoto's, then comes Graves as well. And then we have Addison's, primary adrenal insufficiency, and type 1 diabetes. We had an HbA1c which was normal in this patient. The onset is typically this young adulthood, which is also seen in our patient. Here is a picture of APS and APS2. APS2, which involves thyroiditis, primary adrenal insufficiency is highlighted, and type 1 diabetes is highlighted. As we have gone through again, APS2, Addison's, autoimmune thyroid, type 1, the three manifestations. If two are positive, if two are present, then it is considered APS2. Other associations include autoimmune gastritis, alopecia, vitiligo, celiac, primary ovarian insufficiency, and also pernicious anemia. Prevalence is 1:1000, occurs in adolescence to adulthood. The treatment would be hormone replacement. Prevalence, there was a paper where they had studied APS2 patients for about 13 years, out of which the thyroid disease was 65.6%, and in the thyroid disease patients, 33 had Graves, 32 had Hashimoto's confirmed. Type 1 diabetes was 60%, Addison's was 18.5. When we look at the presentation of each of these three, type 1 diabetes, Addison's, and autoimmune thyroid disease, we have seen that type 1 diabetes had presented earlier, and then came Addison's, and the presentation of autoimmune thyroid disease was the number was low, and presentation was also much later. So when we have a patient with suspicion of this, when we have a patient with the primary hypothyroidism or say primary adrenal insufficiency, do we have to evaluate for polyendocrine syndrome? This recommendation was given in this paper. If they have we have to screen them functionally, clinically. If we have a suspicion, then we need to do evaluation. But even if the patient does not have any features, functional screening every 3 years is recommended. And also there is a familial pattern which is followed. So recommendation is to screen first degree relatives as well. Treatment is hormone replacement, and primary adrenal insufficiency can go into crisis. We need to treat the complications as such. Thank you very much.
Questions? Can you go to your investigations? That antibodies are normal.
Antibodies were normal.
Most commonly, you see Hashimoto's or Graves, you said, no?
Yes.
What is your evidence of thyroiditis in this patient? The enlarged,
The
the
clinic-
fact that it was hyperthyroid and then.
Yes. Classically Hashimoto's thyroiditis, there is a hyperthyroid phase, which comes.
Okay.
And when it is drug modified with antithyroid, they go into hypothyroid state much faster, which we see in this patient. Within a span of 2 months, she has progressed from hyperthyroid state to hypothyroid.
What is the evidence that this patient has Hashimoto's? Like, how do you diagnose usually?
It is Hashimoto's. Majority of the patient have antibody positive, but there is a I don't know the exact percentage, have a antibody negative. B12 was 320.
That is low normal, right?
I've gone through few literature.
What is our lab value?
Our lab value from 195 onwards is considered normal.
Yeah. Yes. So it is low normal only at best. It's not low, right? B12 deficiency per se is not there. Why did you send ANA for this patient?
For the autoimmune causes of primary adrenal insufficiency and if there's any infiltrative.
What particular disease were you thinking of when you sent ANA? Any other questions are there? Thanks.